This is Dr. Mekar. Welcome, everybody. And my guest again is my dear friend, colleague, teacher, mentor, and consultant, infectious disease specialist, Dr. Kenneth Woods. Um, Thanks, Dr. Woods, for joining us again in bringing us all up to date since we have not talked to each other for almost 3 weeks or so. A lot is happened, a lot is happening, and a lot more to come. Just to give you background to all of us, that so far till today, we had almost 24 million cases in the world confirmed, with 827,000 deaths, close to a million coming up in the next few weeks. U.S. again has sadly the dubious distinction of having one of the highest cases, as we know, even though we have 4% of the population, more than 20% of the cases, with close to 5.8 million. That's a lot more than other countries. And we've had close to 179 deaths, 179,000 deaths, almost 180,000 deaths by tomorrow. Um, West Virginia has not done too bad. Ohio probably is not done as well. West Virginia has had only 9,312 cases and 179 deaths, but still a lot. And everywhere is happening. Now, things have changed a lot the last few weeks. So let's start with Dr. And we do have a few questions from the audience that we'll try to cover. So, Dr. Woods, why don't you give us your perspective in the last 2 to 3 weeks, where we are, and then we can take each subject individually and go into more details. So, thanks, Dr. Woods. Go ahead.
No, thank you guys for having me. Happy to share the knowledge of what I have and what I see going on around us with this pandemic. I think the last time we spoke was close to the end of July, maybe first week of August. But at that time, we were seeing sort of the tail end of the spike from the 4th of July holiday. And with the 14-day incubation period, most of those cases were coming in sort of mid-July and having symptoms through the end of July. And so that's when we last spoke. And so where we've kind of come from there to now is we've definitely seen a little bit of a decreasing trend in cases. And so we're not seeing as many new cases develop per day, but we're still continuing to see definitely more cases right now than we were, say, 2 or 3 months ago on a daily basis. So to put that into perspective, this past weekend, I think we had 6 cases over the weekend. So if you look at the July 4th holiday, we were having sometimes 6 or 9 cases a day. So it's definitely a little bit less, but it's not to the paucity of where, we're going days in a row without any new confirmed cases. So we're still seeing new cases coming in, but definitely not as high a volume as we were, this time a month ago, which is good. Or, we're on the downward slope of the incidence curve. As far as the severity, I don't believe we have anybody in the hospital currently or within the past week or so with confirmed cases. And our cases on the Ohio side have been very low acuity, outpatient setting, very minor symptoms, presenting and seeking care. And some of those positives are low or no symptomatic, individuals or asymptomatic that were tested for, some of the other purposes with the mandates going on around us. So very low acuity of the cases that we are seeing, which is good, and definitely a little bit of shift from the acuity we saw, 2 or 3 months ago.
So, yes, same here on this side of the river. There are some questions regarding the testing. Where are we, where the tests are being done today for immediate diagnosis of amongst us who has the COVID-19 positive? And why are some shifts happening recently from CDC recommendations as to who should be tested, who should not be? And in that positive tone, however, before we go any further, I just came across a fascinating news today that one of the companies, Abbott Lab, is going to come up with a potential game changer COVID testing from $5, rapid testing from the nasal. And they're going to be making millions of 50 millions of these kits available by the end of October. So where are we today? And why are some recommendations being changed? And what do you think we should be doing as far as the testing is concerned?
Yeah, so the testing is always a hot topic, and it's been ever changing, as we learn more about the disease and as we learn more about the, the epidemiology and how this is affecting our population. And so right now we currently have really 3 basics of testing. We have the nasopharyngeal swab that's a PCR. We have the nasopharyngeal swab that is an antigen-based test, which is a little bit distinct and different from the PCR. And then we have the antibody test, which is a blood test, which isn't always a venipuncture or blood draw. It can be a simple finger prick test like a glucometer reading, but a few drops of blood is all it takes to give an antibody reading. And so still, the easiest to explain is the antibody test, because there's still no basis for that test in the diagnosis of this disease. It can take upward of 2 or 3 weeks before somebody starts to mount the antibody response. And so it does not tell us really if somebody's symptoms are due to that virus, because it would be a false reassuring negative test. And that said, on the back end, after somebody has the disease, the antibody test can be positive for 6 months, a year later, not distinguishing what's going on currently versus maybe a remote infection 6 months ago. So that antibody test is the least useful of all of our tests, but it has a lot of hype because it has a lot of access, and some of them are very, very quick point of care tests, but just don't have a lot of valid, reliability for diagnosis, more for prevalence testing, surveillance of the population. The other two tests, our gold standard still, or best test, if you will, is the PCR. And so nasopharyngeal swab that's put to a PCR that looks for the actual RNA of the test. So kind of like a DNA fingerprint. It's been purified to as quick as even 15 minutes on some of these assays, and some are trying to develop point of care tests. Typically when we started with these, they were taking us, 8 hours of hands-on time with the old-fashioned ways, with doing pipetting and reagents and using elaborate machines to give us these answers. And we've slowly shortened that with, more mass production of the testing kits. And so those are definitely increasing the throughput and turnaround times of the tests with equal accuracy. That said, that's our best and most accurate test, but still is not perfect, as no test is. And so we can have some folks that have, early onset disease that maybe have a negative test and it's just not high enough to be detectable yet. Some of those would fall into that false negative category, somebody that has the disease, but the test is negative. And so, we talked in the past about as high as 30% can be false negative. And our testing has not really improved on that gap too much, only the repetitive access to the test and the time of getting the answers back. The actual performance of the test hasn't actually changed or improved over these couple months since we've been using PCRs. One more thing we should probably mention with the PCRs is if your incidence is low enough in a population with the disease, you have a chance of false positive results, meaning something else is flagging the test as positive. And so many things can artificially elevate tests, from a DNA or RNA standpoint that may or may not be the virus you're looking for. And so they usually look for specifically 3 or 4 target proteins. And if those proteins are there, the test is flagged as positive. So there's other things that are, common in a community when the disease prevalence is very low that can lead to a false positive. So that would mean somebody that has a positive test but does not have the disease. So a positive COVID PCR but does not have COVID infection. So now that we're having, very low incidence but increased access to the test, we're starting to see some of those peak up with false positives, which in the past we didn't really talk much about because we had such hard time getting access to testing. Those that were testing were more plagued by the false negative results. So something for us certainly to talk about. The antigen test, the third test, is probably our newest, player to the market of antigen or COVID testing. It's very similar to a PCR, but it specifically looks for the protein antigen of the virus. So it's similar to our rapid flu test, if you will. And so typically our rapid flu test would look for influenza antigen with the result available in about 10-ish minutes. But the sensitivity is never as good as a PCR. And so with the COVID antigen testing, it's suspected that the sensitivity is probably in the realm of maybe 60 to 70%. So a little bit lagging behind the PCR, but maybe not as bad as it could be if we were forced to rely on antibody testing or other measures. So it is a test that we have that some folks are using for a lot of mass testing scenarios where they're testing 200 or 300 people because they can be done in rapid succession. So right now, as far as the access to testing goes, there's a lot of very well-respected, names in the business for microbiology testing that have now gotten approval and instrumentation to do testing. And so some of these are just a matter of adapting the equipment that our laboratories had historically. Others, are completely new platforms that might require additional machines and reagents to run. But there were very well respected, names in the community for microbiological testing, to where now we're having a lot more hospitals that can do internal testing. So in the past, we had a very fortunate cooperation with the folks at Franciscan University to do PCR testing on a machine we internally validated. And so now less hospitals are having to try to figure ways to do the testing because we have commercially available testing. So folks can go out and buy, commercial equipment that's licensed and approved with FDA, regulations to do these testing mass scale, which has definitely improved our throughput for testing because less hospitals are relying on the reference labs. And so when folks don't have testing and they have to send a sample to somewhere like Quest or Core Labs, there creates a bottleneck there. So you might have 1,000 hospitals, relying on 2 or 3 labs. And when you have that amount of volume, the reference lab had a hard time keeping up with the samples, sometimes getting 10 or 20,000 samples a day. And so now that we have commercial products available, we have a lot more, freedom and a lot more flexibility with testing that we can individualize it for every organization so that we have, less turnaround time. So when we need the answers the most, we can get answers hopefully within hours instead of days or weeks.
So, to simply make it easier to understand, the antibody testing is only helpful to know that somebody has had the infection. So, that does not have any value for us to diagnose you or me right now as we are talking from far away if we are positive. And between the two testing, the one which used to take 2 to 5 to 7 days to get the results, we are reaching a stage pretty soon where, first of all, any test which takes more than 2 days to get the results is virtually useless in some ways because it does not add on to what we need to diagnose immediately and start contact tracing of that person who's not well. But the new testing that we're talking about, the saliva test that I just mentioned to you from today's front page news, something similar, if that's made available for $5 or something or whatever that, and if it can be used widely with the results immediately, even if it's not very 100% accurate, 60%, 70%, 55% accuracy still is a whole lot better in every direction, every way you can look at. And that's
Absolutely.
what we do, whether it's the school, the colleges, the business offices, hospital, wherever. So that means it'll be a huge, gigantic leap forward if you can have a test which is made available to public at large and hospitals and clinics and doctors' offices or wherever, or sports arenas or anywhere, or businesses, for example, so they can test their persons, whoever was the employee or a student, immediately get the results. This way you can screen out a lot of patients who are potentially sick that particular moment. And that means we need millions of these kits because some of us are going to have to be tested on a frequent basis, like some of the politicians, the ones who have to go out to the public every day under high risk to expose themselves to the infection, they get tested every day. But this test will make it available for us ordinary folks everywhere. So that'll be a positive thing. So antibody testing still has a value in somebody, especially children who get sick, and they didn't even get sick, but they were positive later on with antibody testing. And that also plays a role when we're going to talk about the convalescent plasma treatment that we're going to talk about. So we agree, and you would think that you would recommend that we find a way to start testing which is reasonably accurate, not too much false positive test, not too many negative, too much, and still be 60%, 70%, whatever accuracy, as cheaply as possible, as easily as possible, without the discomfort that people have with the present test, which is the nasopharyngeal, which is very uncomfortable to have it done. So we need it by the millions, we need it soon. It has a tremendous value, and we need it by the hundreds of millions of these kits, not just a few. We should be doing at least 5 million tests a day to be able to start finding amongst us in each area where there's a spread at any particular time of this virus. Is that fair statement?
Very much, yep.
Okay. Now let's talk about
the more access we have to the testing, the more helpful it becomes to us.
right. Even though there's a lot of confusion amongst all of us, as to which test is accurate, which is not. Why are we getting so late in results? But this is what we need to do to make the diagnosis, so we can amongst us separate who amongst us is positive, so that it does not spread. Because in that tone, I was looking at the other day when that motorcycle rally happened in South Dakota a few weeks ago, and there was a lot of concern. There'll be 750,000 people joining and without mask and all that. Sure enough, they did trace 32 some patients from one particular place who have then spread out to different parts of the states. Next week or two is going to show us how much damage that did. It's still, because we have not reached the damage that's been happened. And also, very interestingly, a week ago, I was reading afterwards that in Boston, in February, March, when we did not know much about the mask, the role, and the prevention, in one place where 200 scientists got together for some meeting, or some 200. Out of that, they found there are 32,000 patients from just a gathering of 200 people. So I think we should not take it for granted that this thing is behind us. Clusters of the infection are still going to happen, where super spreaders will spread it. And before we know it, unless we find the testing, isolation, contact tracing, we're going to be having splurges of this in different parts, the hot spots in the different country, which we are still seeing it right now. So I think we have a lot of learning as we go along, but not put our guard down, because this is not behind us. We're still losing 800, 700, 900 persons a day from this in our country. And we're going to talk about that in a minute, about other things too. So let's talk about now what did they say recently? They made a very big news Sunday night that the convalescent plasma suddenly was thought to be a very powerful way to treat the disease. So there was some misunderstanding and absolutely not scientifically correct information about it. Because they tried to make it feel like that the usage of convalescent plasma was reducing the death by 35%. That's not true. What it has a different meaning. So what is your impression about the usage of convalescent plasma in treatment of patients who are critically sick with COVID-19 at any one time?
Yeah. So convalescent plasma is not new. It's something that's been around for many years that we've utilized for treatments for diseases that are poorly understood or have very limited treatment options for. And so essentially you take blood from somebody that has recovered from the infection, that has antibodies for that infection, and you purify that to take out things like the red blood cells and clotting factors that we don't need. And you take the plasma part that contains the antibodies that protect for the virus and inject it into somebody that's actively infected before their body has made antibodies. So we talked about the antibody test. So when it takes 2 or 3 weeks to make antibodies, those 2 or 3 weeks that your body has no antibodies, you have no protection, which is obviously why you're sick and ill. Your body's trying to fight the infection and make the antibodies. But if you were to infuse the antibodies from somebody else that already made them, it jumpstarts, if you will, the process of eradicating the infection. So that's sort of the concept of how it works. Certainly with the earliest phases, and even before we had all the drug trials with hydroxychloroquine and remdesivir and everything else that was trialed, a lot of centers were using convalescent plasma with very good success, because it really does take a high amount of antibodies to somebody that has no antibodies and boosts up their immunological response to the virus. So what it doesn't do, is change the body's response to the virus. It just gives them the jump start or the boost. And so if you're going to have, a severe outcome with the virus that's developing into, additional problems, if you can give somebody convalescent plasma early enough, in theory, you could stop them from getting an overwhelming inflammatory response that leads to the ARDS and lung disease and, ventilation problems. And so the hard part, much like our other treatments, is with this being so new, number one, we don't know the amount of antibody that's protective. So we can quantify it. We can put an exact number as to how much antibody is present in the serum, but we don't know, does it take 100 per ml? Does it take 1,000 per ml, or somewhere in between? We have no idea. We're using our best educated guess to suggest that some threshold needs to be there, because if somebody has 0 or 10 copies of antibodies, that's probably not enough. but we don't know the exact amount that's protective. The other thing that we're unsure of is the timing in that. We know the sooner the better. If somebody has the disease, for 24 hours, they've had it and are diagnosed, confirmed, probably, the ideal time is getting it up front. But if somebody has the disease for, say, 7 days or 10 days, but still has symptoms, and they have worse enough symptoms that say they're critically ill, multi-system organ failure, giving them plasma at that time, will it make a difference? We don't know a lot of those answers. A lot of centers are still trying it for lack of other therapeutics for these individuals, but then we have to factor in the risks of giving them plasma. So we're giving them fluid volume, we're giving them essentially blood transfusions. They're just not red blood cells, right? So folks that have volume status problems, chronic heart failure patients, COPD patients that may be on an edge already with the respiratory or volume statuses, is we're giving them a large volume of intravenous infusion. And so we have risks of reactions. There's other things in plasma as well, not just purified antibodies for coronavirus. We're not as sophisticated that we can isolate just those antibodies. They come with other antibodies. So people that have autoimmune diseases and have reactive antibodies for other things, there's increased risk of having a transfusion type of reaction. And then there's also reactions that are not related to antibody driven, where you can have lung injuries, you can have anaphylactic reactions or allergic types of reactions. So the treatment with serum, is not something that's benign, that should be taken lightly. We have a lot to learn. It is certainly a potential therapeutic option. A lot of our big, academic centers are evaluating, when and how to use it as a best practice, and they're having some very good success. But there's a lot of things that go into that. It's not as simple as a purified product that we're going to infuse from one person to another.
See, that's very important for us to know that this is one more modality in all the other ways we are treating. And the misinformation that we got by saying this is all of a sudden something dramatic which reduces the death rate by 35%, that was not accurately stated by the highest officials of FDA. And that's one reason we are all losing confidence as to who do we believe when you hear all these news. And same thing what happened recently with the CDC. They're changing the guidelines as to who should be tested. What they're saying is that if somebody is exposed to somebody, but there's no symptom, they don't need to be checked. They don't need to have the testing done. Well, that's contrary to what we're telling, that many of us can be pre-symptomatic or asymptomatic and still be carriers of virus. So where do you draw the line as to who should be tested, who should not be tested? So were the CDC and the FDA somehow coerced for political reasons from the higher up to give us the information what suits that particular time instead of being totally scientifically based?
I think a lot of it comes with our increased awareness of the disease. And so, up front, a lot of people were very cautious, and wanted to over-test and overutilize resources. Same thing with, personal protective equipment. Before we could prove that this was coronavirus and it was a droplet transmissible virus, we assumed that it could be airborne and contact transmission, and more contagious than it really was. So everybody was in hazmat suits or PAPRs and wearing N95s for every single patient interaction. There are viruses and there are infections that can spread like that, but we've since learned that coronavirus is not one, and COVID-19 is certainly not one. That most of its transmission is very similar to influenza, with a droplet type of particulate that in common sense is dense and falls to the floor within about 6 feet. And so we know that we don't have to do all those excessive practices for every case anymore. And so, we assume the worst until we can learn about that. The testing was similar to where a lot of people were very nervous and extra cautious. If there was a benefit to testing, they were recommending testing in certain scenarios. I can tell you there's definitely been some, disruption, if you will, between our political environment and our scientific community, to where there's been decisions made on who to test and how to test that have not always been clinically supported. Clinically, we know if you have an exposure today and you were to go get tested today, the statistical chance of you having a positive test from that exposure is 0. You cannot have a positive test from an exposure that day. So if you had a positive test the same day as your exposure, you were harboring the infection or the illness from 4, 5, 7 days earlier. Right. So then it becomes a validity question. Is it still valid to test that person? If they're positive, maybe we prevent the next exposure. There's a lot of things that go into that. So you have to look at when you're ordering the test or acquiring the test, what information do you hope to acquire to help you manage that person or that scenario. If the test doesn't help you manage the patient and it doesn't help you manage the scenario, as a clinician, to me, that's a useless test. So we have to stop and think how the test is going to benefit us. The hard part is exactly that, people that are exposed in tracings and the asymptomatic folks, because most of the time in that setting, the testing is not going to help us based on a PCR test. It's a single snapshot in time, and so if you truly had an exposure that's going to lead to infection, we need that test a week later. 4 or 5 days later is when we would expect that person to develop a potential positive test. So doing the test on ground zero or day zero doesn't help us with that single point exposure. We're learning more and more about this in our regulatory communities. CDC and our health departments are learning as well and trying to follow the data from what the patients that have been infected and the hotspots with lots of volume of cases that can synthesize data and make sense out of it. And as you mentioned earlier, we don't know always who to trust with data. Historically, us as clinicians, our data we would put in a journal, it would be peer reviewed. We would have colleagues that reviewed it and validated that that's appropriate analytical skills with the data to make meaningful results out of it. Even if it wasn't a randomized clinical trial, it was peer reviewed. And with COVID, being brand new in a pandemic, a lot of data is coming out in public forums, on journals and blog sites and social media that, number one, has no peer review, but number two, has no scientific and statistical analysis that have taken place. So it's a lot of anecdotal data. So we really have to watch what we're seeing, what we're reading, because it's not what we're used to. We're used to being able to pick up the New England Journal, and whatever is in there, you can trust some of the evidence behind the data and their synthesis or their conclusions. And right now, there's just so much data and so much we've learned that there's something posted or published in so many different places that's very good data and some that's not. It's just hard to always tell the difference.
But nonetheless, we can still agree in the last 6 months, we learned that using the mask, the right type, the right way is very protective. Even now, they're saying that instead of having just the appearance of a mask, which is not used properly or is not the right kind, is not very helpful. But if you were to have the right mask, like we talked about the last few times, it is likely to reduce the death by 20 to 30,000 in the next few weeks. So we agree on that, no matter what you believe. Else, this is scientifically now. And secondly, also one more thing about the flu, you said, flu vaccine, influenza that we have is not quite as fatal in its outcome as is the COVID-19. Is COVID-19 related illness is 8 to 10 times more dangerous in causing our death than the flu itself. It's not to say flu is insignificant. It still kills hundreds of thousands of people every year, but the rate with which the COVID-19 related death is, and the way it also is so more contagious, both. That's why we are seeing such rapid increase or number of patients we have. So I think we need to, so mask has a value, test which is easily available, accurate, hopefully, and cheap, and get the results right away, are still going to be much used when our children go to school or colleges or sports or where somebody is to go back to work. So there is a tremendous role and the need of those tests at the moment. Now let's talk about a little bit more about the vaccinations. There's a lot going on. There's 100 and some vaccines being made. Where are we, and what do you expect? And also, since amongst us there's such a disdain for accepting the vaccine for flu and pneumonia and shingles, where are we today, and what do we expect? And when is that likely to happen, to the best of your knowledge?
Yeah, so I think they're trying to get a vaccine so that if it is available on a mass scale, it would become the first of the year. So they still have several months to purify and get the study that's done to prove that it's effective. We have several vaccine trials that have proven safety data, and so we know we have products that are safe. They're basically taking similar technologies to our prior vaccines with influenza and other viruses It's just substituting the same technology with new proteins and new virus, particles. And so they swap out with, obviously COVID-19 level of virus. So you build antibody protection for that particular virus. So the safety data is very good and has been approved. They're into the phases now where they're looking at efficacy data. And so far, the preliminary ones are fairly good, but a lot of unknowns we still do not know in terms of the length of time of protection and how many shots or boosters one would take to get lasting protection. We think about some vaccines that are, a series of shots with maybe a booster and you're done, like hepatitis B. You get, 3 shots in a series over 6 months and you're protected for life. And then we think about other vaccines like influenza that you get 1 shot, and you would get a booster the first time, and then you would just get an annual shot after that. But it wears off, we know, after several months. So a typical influenza vaccine would wear off most of its effects by 3 or maybe 4 months later, which is why every year we have to get another influenza vaccine. So what we don't know with COVID yet is when we get a vaccine that's, a high enough efficacy to be, preventative, will it require a booster a month later to give us a level of protection for a significant amount of time? Or will it be a very short-lived infection prevention that would then require repetitive exposure or injection? We don't know the final details on that front.
So we have a tremendous challenge ahead. We may not have the vaccine available, which is proven safe and in mass production. The earliest possible is the first part of the next year. Even then, it may not be widely available for everybody. Even then, half of the population may not even want it because of the whatever reasons we have for not believing in unless we believe the scientists.
Yeah, the latest numbers I've seen was only 10% of the population currently in the U.S. would accept a coronavirus vaccine if it was available, FDA approved, and proven safe and effective.
So that's not enough, though. That's not enough for us to add on to other things to slow down the spread of virus. So we need 30, 40, 50, 60% number amongst us who are willing to take scientifically proven, safe, effective vaccine, whether it's single dose or with the booster when the time comes, if you're lucky enough to get it. Would you be willing to get it when it's available?
I would. I think it's very proven safe at this point. I have no concerns on the safety data. What I don't know, obviously with the limited amounts of data available, is efficacy side. If I were to get one, say today, would I be expected or anticipating getting another one a month later or 6 months later? That I have no answer for us yet today. I feel very safe as far as getting one today. If they gave me even a 15% chance of prevention, certainly in my line of work and seeing a lot, of these patients, that would be worth it to me, even if it's not 100% effective. Our influenza vaccine, I hate to keep going back to that, but it's never been 100% effective. But that's one that I've gotten every year for the last, more than a decade, as far as my level of protection. So, I think it's proven enough to me that it's a safety, safety proven vaccine. It's just a matter of the efficacy and when would we need to get another one, or how long would it protect me? I just don't have a good answer for that.
So when the time comes in the United States or other countries of the world to have the effective, safe vaccine, affordable, and they can mass produce by the billions, only then we are likely to have the benefit as a whole in the world. Because if one country has it, one country doesn't, it doesn't mean that everybody else is still safe. So we have tremendous challenges ahead as far as the vaccine is concerned. Now let's talk about the schools and colleges, sports. Where are we and where are we headed, and nothing, we're learning every week as to how some schools open too quickly and then they have to close it. Teachers are getting afraid. Parents are afraid. Parents are in a very challenging times. Those who have to have their children in school for many reasons. Where are we in our community and as a whole as a nation?
So, the schools are a little bit divided with where they're located, and the local health departments and the state level, guidance put forth. But they're all doing a lot of additive protection for students. So our schools in Pennsylvania just went back this week. I think the Ohio schools are going back not next week, but the week after that. So some of the things they've put in place is they've, separated desks to leave the 6-foot social distancing. Some of them have decreased class sizes, and with that, they've had a lot of schools offering, virtual home or virtual schooling, so where they would log in from a laptop from home to do their virtual education, and stay home. So that's, somewhat decreased class sizes and ratios. In Pennsylvania, they've required, I think Ohio just last week mandated this as well, but the kids coming back to in-person instruction have to wear a mask while they're in the school with certain, allowable mask breaks, if you will. So when they're doing instruction in the classroom, they're wearing masks, and the teachers are doing the same with masks, plus or minus, face shields in some of the settings. They're pushing to try to get a lot more classroom activities outside, which is a great thing with fresh air and UV light killing viruses. So they're, our schools, for example, have asked for parents to bring in with their child their typical, box of crayons, pencils, whatever, and they're asking for a foam stadium seat. So when they go outside into the courtyards, they can have the kids with a stadium seat to sit on, and they can, maybe have science class outside discussing the trees and the leaves and the seasons, whatever they're doing with their instruction, which is, I think, a great, integration with what they're doing. They get a better hands-on experience and actually enhances their education more than a classroom and a book would do. And at the same time, it's obviously safer from a communicability standpoint being outside. So that's some of the things they've done on our side in Pennsylvania. Some of the things they're also, beefing up is the disinfection. So they're asking for donations from families as far as like the Clorox or Lysol disinfectant wipes and sprays. And so they're going, before the kids eat their lunches, they're sanitizing all of their desktops, they're doing their hands. All of the kids have a alcohol pump or a Purell type of pump at their desk for their hand sanitizers, which typically in the, years ago past, we wouldn't even think of those things in a classroom. We would clean the classroom maybe at the end of the day if it was dirty, or the janitorial staff, mopped the floors and emptied the trash, but they didn't necessarily sanitize or disinfect doorknobs, sinks, bathrooms got hit, maybe once a day, whereas now our, Pennsylvania bathrooms are doing it 3 to 4 times a day. So, they've definitely beefed up a lot of things to try to prevent spread of things, coronavirus and the like, that I think is taken a step above and beyond, because, they're not mandated to do a lot of these things, but they want to do what we know from the healthcare setting can be best practices to decrease transmission. Obviously, the most vulnerable population they have, with the children and the youth, is those that are, asymptomatic, have the disease, and we don't know it. That's the hardest population, because if someone has a fever and a cough, we can assume they're infectious and try to keep them home and isolated from going to work or going to school. But when that age group doesn't have any symptoms but are shedding the virus, they have a different fate ahead of them than us in the hospital, where we're used to people presenting with symptoms. So I think they've gone above and beyond to do that.
Okay, let's say a few words about how well our country, United States, has done compared to the rest of the world as far as the COVID-19 related handling of the pandemic. And I was just reading from today, we are way down the list of the one who have done well. Denmark, Australia, Canada, Germany, Netherlands, South Korea, Italy, Sweden, Belgium, France, Japan, Spain are ahead of us in everything pertaining to COVID-19 pandemic. Then comes United States and United Kingdom. Why are we having such hard time accepting science-based information and recommendations and following it? Why? What is about us that we think we are invincible, or we don't need to follow the guidelines?
I think there's a lot of things that go into that. I think there's a lot of American, people that in the early days, thought that this was a made up, plot to try to get people to do one thing or another, or stay home, or this, that, the other thing. And so I think there's a lot of people that are, just not truly supporting or believing the severity of the situation. Compound that with a lot of the social media that then has mixed messages, some that are appropriate and some that are not. Some have, the intention to be accurate and relay, information correctly, but sources are obviously the critical piece there as far as what's accurate. And so, a lot of our, public reporting, our news sectors and things that have put information out so fast has not always been accurate. And so it's kind of, in my eyes, with the lay public or the non-medical trained public, has kind of done one of two things. It's scared a large population to where they have a lot of anxiety and are afraid to leave their house, and they're afraid to do anything, including just go to their doctor's visits and such, because they're so overwhelmed with fear of getting or dying of coronavirus that they've literally shut down and become isolated. And then the opposite side of that being the folks that undervalue the importance of it, that are out in public without their mask, not social distancing, that truly don't appreciate how severe this can be, as a virus infection that we have very little, if not no, therapeutic options for. So I think compounding all of that together has led to us having different outcomes than a lot of other countries in the rest of the world. We've always had the American dream and views of having freedom of speech and freedom with a lot of our activities, and then some of that gets limited by our mandated quarantines and the social structure being shut down, the shopping and the restaurants and the typical ways of life for many people shut down, that then back funnels into having the different levels of our interaction, that once those open back up, people just were all over the map as far as being afraid or being just okay to go back to normal. And it's that middle ground, trying to get people to realize what this is, educate people on the disease and the virus, like we're trying to do with these sessions, so that we don't have the extremes. We have people that may not have medical backgrounds or education formally, but have the knowledge we can give them of what this disease is, how they can prevent this, protect
And we
themselves.
keep learning and sharing with everybody.
That's exactly right.
A couple of more points I want to make. I may have lost you for a moment. A couple of things I want to say that I mentioned a few weeks ago, that with the modern technology we have, now COVID-19 tracking applications are being made available on telephones, which are being supported by Apple and Google. That's something new that we're doing in this country that we did not do before. We are trying to use the from national resources and these companies, where you and I can use our telephones without losing our privacy, and be able to be part of a system where any of us who is found to be positive can be traced immediately and go back the last few days what my contacts were. So this is something very exciting which is happening. 10% or so of some populations, some states are using it. I think in the next few weeks we're going to be using more and more this technology, so we can immediately detect when in some places there's a cluster of patients, immediately detect them, isolate them, and have the contact tracing. Let's say a few words also. The flu season coming up. We need to emphasize to all our patients and public at large that flu vaccine still plays a tremendous role, and pneumonia vaccine plays a tremendous role. Whether or not we have a COVID-19 vaccine, that will be additional one more help for us. But we should not underestimate that when we have flu season coming up, we hope we don't let our guard down and be negligent in taking care of it as best as we can. So the next 2-3 months, along with that, with the hurricane and all those problems happening in southern parts of the United States now, that's going to add additional burden to people who are at high risk to begin with, COVID-related problems, and now with no lack of electricity, proper water, proper shelter. So we have the next few weeks, a few months still challenges. So I hope we keep learning and sharing with each other this information. What do you still recommend on a day-to-day basis for us? That we must continue to use the mask properly, safe distancing, social distancing, still not go out in crowded places, still have the hand washing frequently, and continue to do what we have been doing all this time, and not let our guard down. What else would you like us to sort of follow from your point of view, being the expert in this field?
Yeah, so I do want to go back to the masking. So we do have some new information since our last session with the gator type of mask, the scarf mask that goes around the neck, that comes all the way around, that you can pull up to the nose and mouth. They frequently are called the gator mask. And so we have, CDC and NIH that have supported that those masks have several trials now that actually increase the spread of coronavirus. So they are not recommended So they, number one, increase the risk of you getting it while you're wearing it. And number two, if you have coronavirus, they can increase the risk of you giving it to those around you while wearing it.
Now, why is that?
Certainly, I can go into it in a second, but certainly it's increased risk over the surgical mask or simple face mask, and increased risk over a cloth mask that would loop around the ears, but have a more dense cloth across the mouth and the nose. And so they're looking at even comparing the gaiter type of mask versus nothing, so bare face, and it looks as if it's even higher risk than having nothing on whatsoever. There's some folks down at Duke University looking into it and trying to put some studies together, retrospective data. And so some of the hypotheses between that is the way that one pulls that mask up and over the face requires a lot of hands-on touching of the mask. And if it's contaminated to where you're touching your face, the mask repetitively, as opposed to the kind that go around the ears or loop onto the back of the head, you typically would touch that by the ear loops to place around your head, not the part that's contaminated while you're breathing. And so there's less contamination of your hands. The other type with the gaiter, a lot of them are irreversible to where you can't tell the inside, the outside. And if the outside's now contaminated versus the inside, you've coughed and sneezed your coronavirus on the inside and pulled it down because you left the grocery store and drove to the gas station and went to another place and put it back up, and now that's flipped to the external surface and just shedding with every exhale. There's a lot of hypotheses as to why that might be the case. The latest one I actually just heard today in an email was that the material that's used in some of these is very, very thin, and as the virus is coming out of the mouth and nose, it may actually infract the viral particle like an aerosol or nebulizer and stay suspended in air longer than if you just coughed out the same particle with nothing in its path. You would cough it out, it'd be heavy, dense, and intact, it would fall to the ground. But if it's able to go through a filtration and split that particle into, say, 4 or 5 particles that are smaller density, they stay suspended in the air. And now the next person that comes by, is able to inhale those and propagate the disease. So I will mention that because the gaiters have some increased risk right now and are not recommended for use as far as protection of somebody that's sick or somebody that's protecting themselves from those around them compared to the cloth mask. So I certainly recommend the cloth mask. If you don't have surgical masks or a medical grade mask, some of those are equally effective, but they have to be the type that goes around the ears and has a full face, nose, and mouth have to be covered.
So it's very nice of you to be able to explain. In the last many months, you and I have evolved, learning initially when we didn't talk about masks at all and say, well, we don't know it's going to do any good. Now you and I have seen in person in the offices and otherwise people who just pretend they have the mask on and they have it around the neck or have the terrible type of mask. And now you are showing anatomically why bad mask is worse than having no mask at all. So we need to emphasize only in the last 3 days in my office, I came across patients, some who didn't want to wear the mask, some I could see through their mask. And so everything you're telling me is practical of big value. And we don't need expensive masks to use. We don't need N95. We need an ordinary, good, solid 2-layer cloth mask preferably. And you should not be able to see through it. And you can use it that if you blow through it, if you can't put the candle out, that means it's pretty good. If you blow through it and the candle goes, the flame goes out. So there are different ways. So I think you and I will continue to emphasize that the masks are tremendously important. And I think I was looking at the map today as to how many states in the United States are mandating masks in public. I think at least half the states are. And I think we need to continue to not let our guard down. Only the last few days, again, we've seen some public gathering of people where there was no mask at all and there was less than 3 feet distance between people. So I think you and I are going to continue to come and say, we as in medical field, we do feel the masks are extremely important, particularly if they're the right kind, at the right place, for the right reason. And bad mask is worse than not having a mask. Yep. What else would you like us to learn more and be prepared ourselves the next few weeks? What is your hope? What is your recommendation? Anything else would you like us to?
Like you said earlier, hand sanitizing. So alcohol Purell, Germex, whatever brand, as long as that's at least 60% alcohol, rub for 15 seconds on the hands, very effective. The hard part with what we're touching is we touch so many surfaces in our life, whether it's at work, it's at school, it's going to the gas station, you touch the gas pump and the buttons on your ATM machine. You're touching so many things, and you never know who touched them. An hour ago, 15 minutes ago, and so every time you're using and touching things, washing hands, and certainly before touching your mask, your face, eating, that's the most crucial time for washing hands. And so we can't forget that as well. So I think hand in hand, the mask with very good hand washing has the potential to still help us and decrease the amount of people infected with this. If I could take one point home, that's the one that's the most crucial still.
In the meantime, we still need to continue practice good hygiene, get fresh air, get well rested at night. People who don't rest well also are high risk, along with the other risk factors. We have the diabetes and the age and the heart problem and the obesity and the inactivity. So we need to continue to be aware that everything we do affects us in one way or the other. And we have a lot of challenges ahead. So hopefully the next few weeks, we'll see some improvement in the decrease in the incidence of this problem, and hopefully we'll have come up with better, in addition to remdesivir and other modalities of treatment for people who are critically sick. But mostly the only way we're going to get into the control is if we start doing everything so we can slow down the spread of the disease, so it's not like in clusters where we get by the thousands. And hopefully in 6 months or a year, we'll go back and start looking at it and say this is under control. But unless the whole world comes together, controlling in one country alone or one state or one county is not going to be the answer to this pandemic. We're going to have to sort of take this as the long-term view for the whole world to be together somehow. That's at least the way I see it.
Yeah.
So anything else would you like to add? I think it's been wonderful learning from you many things, and I hope you will keep coming back when you have time.
Very good. Well, I'm happy to share.
Thank you, everybody out there, and I hope we all got something out of this session. Thank you. Till we meet again. This is Dr. Mekar with Dr. Woods, my guest, and thank you all there.
Thank you.
Thank you. Bye-bye.